Thank you very much for inviting me here. Congratulations to the organizing committee for the fourth conference in Crete. Always good to be here with friends, old friends, mentors. I spent my 6 years of medical school here, so very good memories. So I'm going to talk about for the sake of time, I'm going to talk about the clinical practice guideline that we're actually formulating at the moment on the management of patients with IPF and lung cancer. So regarding the overview, I'm going to perform an introduction about the close relationship, pathogenetic and clinical relationship, and epidemiologic relationship between IPF and lung cancer. And then I'm going to talk about the PICO questions that we have formulated on that to produce this task force that has been funded by ERS, and I'm going to summarize our major findings so far. So regarding the IPF comorbidities, as you all know that patients with lung fibrosis, they come along with many comorbidities. We're going to focus on lung cancer, which as you can see here, it increases the hazard ratio of mortality of about 2 to 3. What is worrisome at the moment is we have a cumulative incidence of lung cancer in patients with IPF. That means in this retrospective analysis, including more than 1,500, about 1,800 patients, about 3,000 actually patients with IPF, we saw that almost 10% of them, they develop lung cancer during their disease course. And as you can see here, the most prominent and prevalent diagnosis is squamous carcinoma and also adenocarcinoma. But what is in the analysis that we did from this retrospective multicentric analysis was that almost 1/3 of patients during their disease clinical course, they're going to develop lung cancer. That means that within 7 to 8 years, they're going to develop lung cancer after the diagnosis. And if somebody wonders, like if a patient with IPF can live up to 7 or 8 or 10 years after the disease diagnosis, yes, with the invention and with the application of antifibrotics, we have patients with lung fibrosis that they live up to 10 years. Regarding the interrelationship between these two entities, they have many common pathogenic pathways, the so-called carcinoma. I'm not going to go into details, but both of them, they represent distinct course of the same devil. And the devil is alveolar epithelial cell apoptosis, metaplasia, remodeling that leads to carcinogenesis. And why do we care about this kind of comorbidity? Does it affect survival in this patient? And the answer is a resounding yes, because lung cancer has a negative impact on IPF survival related to TNM staging. As you can see here, if a patient has a TNM staging of 4, then it has a 3-fold worse survival if the patient has IPF. So that means that we do worry about these kind of patients because the coexistence increases drastically the mortality in these patients. But what is worrisome at the moment, and what we have figured out with this global survey that we performed a few years ago, the dimorphosis survey, was the fact that only there was a considerable lack of knowledge on diagnosing and therapeutic strategies. We don't know how to manage those patients. We don't have standard operating procedures. Most of the studies that have these kind of algorithms, management algorithms, they derive from Asian countries, and also patients with ILD and lung cancer are excluded from antifibrotic randomized control trials. That means we don't know the effectiveness or the efficacy of antifibrotic treatment in patients with IPF and lung cancer. And the most worrisome thing is that we have decreased awareness on the coexistence of these two entities. So we decided to formulate this task force. It has been funded finally from ERS. It was a task force that it encompassed 18 experts from 5 different assemblies of ERS, 3 different societies also. We had members from Japanese Respiratory Society and also American Thoracic Society. And among others, there were 2 Greeks. The former speaker, Georgia Hardavella, is one of the members. And this is how we allocated the tasks. We formulated 7 PICO questions and 2 narrative questions that I'm going to go into brief detail in the following slides. And this is how we allocated the tasks. So each member had to do specific tasks in order to make the systematic literature review, and then perform the data extraction. You had to familiarize yourself with this really exciting software, the so-called Covidence for systematic review, which is simple, at least to my, at least based on my knowledge, and it has like really nice tutorials inside of that. And everyone who wants to do a systematic review, it needs to be familiarized with Covidence. And as you can see here, it has specific steps. First, you import the references, then you perform the title and the abstract screening, then the full text review. You filter actually the most important and relevant studies based on your PICO question, and then you perform the data extraction and the quality assessment. And regarding the PICO questions, so the first PICO question, that most of them, they were patient-centered. So we had also patients that were involved in the formulation of PICO questions. So the first PICO question was, in patients with IPF and lung cancer, should antifibrotics be continued? Can they be combined with oncological treatment versus no oncological treatment alone? And there's a rationale behind this question. The rationale is that there are retrospective analyses, there are retrospective studies showing, for example, that pirfenidone reduces the perioperative acute exacerbations in patients with IPF lung cancer. So just to simplify that, we know that patients with IPF, if they undergo surgery, if they undergo anesthesia, general anesthesia, they tend to they have increased hazard ratio for acute exacerbation that leads to increased mortality. And studies have shown, many of them they derive from Japan, have shown that if these patients they are under antifibrotic treatment, then that, for example, with pirfenidone, then that reduces almost sevenfold the perioperative risk of mortality. And this is an indication. And we have shown that in our retrospective analysis published a few years ago, showing that patients with IPF that they were under antifibrotic treatment, they had reduced mortality by almost twofold if they also had lung cancer compared to patients that they were not under antifibrotic treatment. And there's also a prospective study, the only so far prospective randomized controlled trial coming from Japan, showing that patients with IPF and lung cancer under nintedanib treatment with standard of care, paclitaxel with carboplatin, versus no nintedanib treatment. So patients that were under nintedanib treatment, they tend to have better survival if they had adenocarcinoma or otherwise specified non-squamous histology carcinoma, saying that we know that from oncology that patients with squamous carcinoma, they tend to have worse prognosis if they are given anti-VEGF factors like bevacizumab. So I think we need to bear that in mind, that patients with IPF and lung cancer, if they have a squamous cell lung cancer, we should be careful when we administer nintedanib, which is also an inhibitor of angiogenesis. The second PICO question was formulated, and it had to do with a technically resectable non-small cell lung cancer. And the question was whether these patients they should undergo lung resection versus no lung resection. And the rationale behind of that was, again, these patients, they can experience acute exacerbation if they undergo extensive lung surgeries. And as you can see here, the postoperative mortality has been increasing in patients with IPF. It's about 7% versus 2% in the general population. That's why you need to carefully select those patients. But what our analysis have shown, and also other studies have shown, is that if the patient is fit enough with mild functional impairment, then we better perform surgery. That means, as you can see here from this graph, that patients they had technically resectable non-small cell lung cancer. They had good fitness status. They had good performance status. If they undergo surgery, then they had better survival of showing by this graph of about 76% difference. And also, we should bear in mind, and I'm going to develop that in the next few slides, that if so now the tendency in thoracic surgery is that they perform lung preservation volume surgeries. That means they perform segmentectomies versus lobectomies because they have less complications. And we should have that in mind, and also inform or have a close contact with our anesthesiologists and also our thoracic surgeons about the extension of these surgeries, because these patients, they have reduced lung volume and they also have the tendency to develop acute exacerbation if they undergo general anesthesia. Third pick a question. In patients with IPF diagnosed with technically resectable non-small cell lung cancer, should we apply radiotherapy or not? And the rationale behind that question is we know that from student years that SBRT has been, stereotactic radiotherapy has been closely associated with radiation pneumonitis in the general population. And this hazard ratio goes up to 5 times higher if a patient has lung fibrosis. And in most of the cases, this is a fatal radiation pneumonitis. That's why we need to be very careful, and we need to come in contact with our radiotherapists if a patient has not only lung fibrosis, but even like small interstitial lung abnormalities, because that can change also the clinical course of the disease and the response to radiotherapy, and also the complications. So the fourth PICO question was related to radiochemotherapy in patients with locally advanced unresectable non-small cell lung cancer. And the fifth PICO question, these are combo questions because they have like a common rationale. Again, in patients with advanced lung cancer, should we apply systemic chemotherapy or not versus no systemic chemotherapy? And the rationale behind this question is, again, chemotherapy in patients with interstitial lung diseases has a tendency to decrease survival, to promote acute exacerbations, but not only chemotherapeutic agents. As you can see here, studies coming from Japan, paclitaxel and vinolorbine, they seem to have less hazard. They seem to hamper less hazard in patients with interstitial lung disease. But again, we need more prospective data. The sixth PICO question was related to advanced non-small cell lung cancer, stage 4. And it was related to, should we apply immunotherapy or not? Should we be afraid of applying immunotherapy in these patients? Because there's a lot of studies showing that immunotherapy can promote lung fibrosis and interstitial lung disease. And the seventh PICO question, again, had to do with whether we should apply targeted therapy in patients that they had an advanced targetable oncologic driver mutation lung cancer. And again, the rationale between these two questions was about regarding the tyrosine kinase inhibitors. As you can see here, the pro was the efficacy. As we know that patients that they have an oncogenic addiction, the TKIs are the standard of care at the moment. And also regarding the immune checkpoint inhibitors, pembrolizumab and nivolumab are almost like a first-line treatment in patients with a non-small cell lung cancer 1B and also up to TNM staging 4. But the con was there were a lot of retrospective series and anecdotal case series showing that immune checkpoint inhibitors and TKIs can promote ILDs and also can create de novo interstitial lung disease. My personal view, and also many experts involved in this guideline, in this task force, was that if there are oncologic driver mutations, then we should apply TKIs, but we need to carefully evaluate with CT scan every 2 to 3 weeks, at 2 to 3 weeks after the application of TKIs, and also have a close monitor of these patients, irrespective of symptoms. And also, if a patient has more than 50% PD-L1 expression, then we shouldn't be afraid of immunotherapy, because studies have shown that pembrolizumab and nivolumab can be equally efficacious and also safe. And the second opinion was had to do with the body weight adjustment of ICIs, and I think this is open for discussion because there were some experimental data coming from our study group showing that low doses of pembrolizumab can exert antifibrotic properties, as you can see here in the bleomycin-induced lung fibrosis. If you give bleomycin, then you see like dense fibrosis indicated by muscle trichrome staining with architectural distortion, as you can see here from Ashcroft score that is increased. However, if you give both high and low doses pembrolizumab, they're effective, but low doses of pembrolizumab are more effective. And maybe that has to do also with immunomodulatory properties that have been promoted by pembrolizumab. And also, we should never forget that nintedanib was seminally coined out as an anti-cancer drug in high doses, but in lower doses, it showed antifibrotic properties. So through drug repurposing, we may discover novel therapeutic agents for patients with IPF and lung cancer. And we also had two narrative questions that they were kind of broad in terms of searching analysis. And the first narrative question had to do with the factors that influence the decision to monitor patients with IPF. Just to simplify that narrative question, should we monitor patients with lung fibrosis for lung cancer development? And if yes, how often? And also when? And with what modalities? And if you go through the NCCN guidelines and the US Preventive Services Task Force recommendation statement, you can see here that patients with lung fibrosis and obstructive lung disease, they belong to the high-risk groups. So these patients have increased risk of developing lung cancer. So what the task force suggests for the moment, based on the literature review, is that these patients, they should be closely monitored with low dose or HRCT for the development of lung cancer every year. So regarding the low dose or the HRCT, if we actually monitor the progression of lung fibrosis or the development of lung cancer, this is also open for discussion. There's no evidence-based data at the moment. The second narrative question had to do with the factors that we need to apply in order to decrease the morbidity and mortality associated to oncological treatment. In other words, what we should be careful and what factor we should take into account in order to reduce the morbidity and mortality of a patient with IPF that is supposed to undergo lung surgery. And factors that have been associated with increased mortality, perioperative and postoperative mortality in these patients, in this large cohort, Japanese cohort, comprising of almost 1,800 patients with ILD and lung cancer, was the duration of surgery. So we should talk with our thoracic surgeons that the duration of surgery should be as limited as they can. The oxygen concentration, we don't need high FiO2 levels in these patients, and also the flow intake and the loss of balance. So we should monitor those patients closely because they have diastolic dysfunction. They can easily develop pulmonary edema following the surgery if they lose fluid balance. And just to summarize up, and sum up all these findings, this is a busy algorithm. Of course, we're not going to go into details for the sake of time, but just to simplify this algorithm, what we suggest for the moment, based on the literature review that we have performed, is that we should perform an annual screening of these patients because they belong to high-risk group of developing lung cancer. The approach, the treatment approaches and the diagnostic approach that are going to apply in these patients, they are related to the performance status, the TNM staging, the IPF severity, and also patient willingness of performing those modalities. Also, the location of the lesion plays an important role. If you have a central lesion or a peripheral lesion, if you have a lesion that is close to the honeycomb area, you should be very careful if you irradiate this lesion. Or, for example, if you have a patient that has enlarged lymph nodes, then you can perform EBUS, which is very safe, even in patients with low functional status. And you shouldn't be afraid of performing EBUS in patients with IPF. We should avoid irradiation. We should beware of surgical intervention, should be very careful and in very close contact with our anesthesiologists and our thoracic surgeons. And also, we should definitely continue antifibrotics. Platinum doublets represent the first-line treatment for non-small cell lung cancer. And I think they should be applied even in patients with IPF. And regarding TKIs and ICIs, these should be applied on a case-by-case basis. Regarding the areas of major uncertainty is what we do with patients that they have combination of pulmonary fibrosis and emphysema, and what we do with patients that have ILAs. And regarding ILAs, they're more common than diabetes in the general population, as big studies like Framingham study have shown so far. So about 10% of patients with more than 70 years old and they're smokers, they have ILAs in their CT scan. And regarding the million-dollar question is, do all these caveats that I presented before with resection, chemotherapy, and radiation apply also to patients with ILA? And the answer is yes, because recent meta-analysis published in scientific reports have shown that patients with ILA, they have 2 to 7 times higher risk for radiation pneumonitis and 3 times higher risk for ICI-induced interstitial lung disease. And with that, I'm going to finish my presentation.